Hello, we are TechStat Health Solutions, and today we'll be presenting our work on chronic kidney disease detection and prevention in the US. In the following few slides, I'll be going over the project overview, the financial impact, and goals for our project. Now, kidneys are crucial for filtering the body's blood of any toxins or waste products. The damage done to kidneys not only make their biological processes less effective, but the damage is pretty irreversible. According to the CDC, an approximate 37 million adults in the US have chronic kidney disease, and only 1 out of 10 people are aware of their condition. Our healthcare consulting company is dedicated to developing solutions for CKD and end-stage renal disease detection and prevention. Our application dashboard is a user-friendly source for relevant findings that we've gathered through our research, and we expect it to become a pivotal tool for patients and providers alike. Spencer will provide specific details for our application later during this presentation. According to the Medicare spending data from 2020, the average costs for patients with CKD and ESRD were 2.6 and 8.8 times more than that for patients without either disease, respectively. A significant amount of financial burden on the US healthcare system can potentially be ameliorated by implementing an early detection and prevention system. Our team has begun with fulfilling our goals by thorough analysis of datasets consisting of biological markers, as well as datasets that have more focus on possible potential environmental contributors such as water or air qualities. Now you might be wondering to yourself, how do the qualities of everything outside my body affect inside my body? Most specifically, the kidneys. Well, you'll have to continue listening in order to find out whether or not there is a correlation and effect. Using insights coming from these analyses, the most predictive or influential variables were used to help make a more accurate predictive model for CKD. Model experimentation has been conducted in order to develop the highest performing model, and the application necessary to reach physicians and patients have utilized all of this good information, as well as recommendations that we've concluded in order to ultimately support the improvement of public health relating to CKD and, in part, to gradually improve our country's environmental and financial status.
In order to accomplish our aims, we needed a data set that provided medical readings and a target variable that indicated, yes, this patient has CKD, or no, they do not. Our team sent a search party to find such a data set, and we were actually able to locate a few data sets that matched this description. Both data sets have a lot of similarities, namely, both contain 400 records. However, one data set had no missing values and no explanation as to how they handle the missing values if that were necessary. It was a little too suspect, so we opted to use the data set with missing values. Once we had the information we needed, it was time for the rubber to meet the road. Our team was ready to do some exploratory data analysis, cleanup, and modeling. Before we dive into that, allow me to give a brief overview of our data set. Our chosen data set was sourced from Dr. Soundarapandian, who works at the Apollo Hospitals out of India. The dataset contains 400 real-world instances of blood draws administered over a 2-month span. It contains 25 attributes. The dataset contains a lot of dimensions and missing information that need to be addressed. You may wonder how much data is missing, and the answer to that question is 1,009 entries, which is roughly 10.5% of the data. A bar plot distribution of missing values by fields highlights the red blood cells, red blood cell count, white blood cell count are the top 3 fields missing values. Our team researched several methods for imputation of missing data. After much consideration, it was our determination that nearest neighbor imputation, or KNN imputation, from the scikit-learn package would be the best method for null value replacement. What about extreme outliers, you may ask? Without getting too far ahead of ourselves, we built a program that detected, removed, and replaced extreme outliers, or outliers 3 standard deviations outside the mean. Using KNN imputation, we ran and compared the results of a logistic regression. The results were essentially indifferent. For that reason, we opted to keep the original data intact. The preceding slides will demonstrate what we learned from the exploratory data analysis. EDA illustrated a few key points. First, we discovered that 250 of the 400 entries have CKD. The remaining 150 do not. This sample has more CKD cases than not. According to the CDC, 15% of U.S. adults are estimated to have CKD, which is 5% higher than what is estimated for the Indian population. Evidently, this data set does not accurately capture the ratios in census data. However, we believe it to be a large enough sample to work with. A bar graph frequencies of the age group reveals a normal distribution skewed left. This could explain the higher frequency of CKD cases from the dataset. This makes sense, as chronic kidney disease occurs over a prolonged period of time where repeated damage is done to the kidneys. As we mentioned, the CKD datasets contains a lot of dimensions. This gave us a reason to cut down on the dimensionality of the dataset. We explored principal component analysis both with and without categorical data with a 90% cutoff. Without categorical data, 9% of the information was captured using 9 principal components. With categorical data, it takes about 15 principal components to capture 90% of the information. We use this information to set the hyperparameters for the logistic regression and record the results in the subsequent table. As you can see, both the PCA models perform admirably. While the model with the categorical data garnered a slight edge, both models perform better with PCA than without. Similarly, we experimented with employing t-distributed stochastic neighbor embedding. This scatter plot illustrates CKD and non-CKD cases by TSNE. Non-CKD cases are in red, while CKD is in blue. We can see there is a clear-cut distinction between CKD and non-CKD cases. There is little to no overlap. However, given the complications of employing TSNE, we chose to employ PCA instead. Further, TSNE is not as malleable as PCA when adopting new data. In an effort to maximize deployment of our application, we sought out the most necessary features of the datasets. Not all information is going to be readily available from patient visits. It is imperative we configure the assortment of the top 5 most important features of our dataset when determining if the patient has CKD or not. This bar chart is a list of the top 10 features in descending order of importance. The top 5 that made the cut are diabetes mellitus, hemoglobin, hypertension, packed cell volume, and specific gravity, in order of lesser to greater importance. Narrowing in on these key features allows for less rigidity when using an application. Finally, we have a model comparison when using the CKD dataset. The results from the various model types are recorded into this table. The results are mostly great, with the exception of the naive Bayes model type with scale data, which perform rather shabbily in the 80% range. The most consistent and best results came from the PCA with scale data. Decision tree and random forest performed the best on all 3 datasets.
As part of TechStat's holistic approach to chronic kidney disease detection and prevention, we explored several potential external factors that may influence CKD prevalence. The first factor we will discuss is water quality. Contaminated water, specifically water contaminated with heavy metals, has been shown to be linked to chronic kidney disease. Humans rely on local water sources to drink, cook and clean with, and bathe. Each of these activities introduces water and its potential contaminants onto the skin and into the body. Using contaminated water for these activities increases exposure to heavy metals and can therefore increase the risk of developing CKD. 4 heavy metals were studied that are associated with kidney damage and disease per the U.S. Environmental Protection Agency. These are arsenic, cadmium, lead, and mercury. To study levels of arsenic, cadmium, lead, and mercury in water across the U.S. and how they may be linked to CKD prevalence in the U.S., two different data sets were used. The first data set was water quality data gathered from the National Water Quality Monitoring Council. The data contains test results for the 4 heavy metals of interest from water sources throughout the U.S. collected and tested during 2022. Data used for the analysis were sample longitude and latitude, contaminant name, test result, and unit of measure of the test result. The second data set was CKD prevalence by U.S. county, gathered from the U.S. CDC under the Kidney Disease Surveillance System for the year 2019, which is the most current data available. This data contains population percentage of each U.S. county that has been diagnosed with chronic kidney disease and geographic location data for each county. Each of the 4 heavy metal contaminants has a safety limit set by the EPA for concentration in drinking water. These are for mercury, 2 micrograms per liter, for cadmium, 5 micrograms per liter, for arsenic, 10 micrograms per liter, and for lead, 15 micrograms per liter. Box plots were created for each contaminant to display the spread of data. The dotted red line in each plot shows the EPA safety limit. Based on the box plot visualizations, each contaminant has been detected above the EPA safety limits in some locations, but most data collected are at or below the limit. The stacked bar chart at the bottom of the slide shows the proportion of test results that were at or below the EPA limit and above the EPA limit for each water contaminant. For the next analysis, all test results at or below the EPA limit were removed from the data in order to study locations with contaminants exceeding the safety limit for drinking water. The 2 sets of data were combined to create a map to display CKD prevalence in U.S. counties, shown in blue, as well as locations of unsafe levels of each arsenic in red, lead in orange, cadmium in purple, and mercury in green. Focusing on the prevalence of diagnosed CKD first, the counties with the highest prevalence of CKD, over 25%, are located in Hawaii, Southern California, Southern Nevada, Florida, Appalachia, and the Midwest. Based on the locations of water exceeding safe contaminant levels, there are a few places in the U.S. with clusters of contaminated water. These locations are in Hawaii, Montana, Florida, and South Carolina. Based on these clusters of contaminated water, it is not likely that contaminated water is contributing much to nationwide prevalence of chronic kidney disease, but it would help the overall health of people in these local areas to improve the quality of their water. The next factor we explored that may influence CKD prevalence is air quality. Like water, people rely on air every day to live. Since we are constantly breathing in the air around us, the quality of the air and concentration of pollutants in the air can impact our overall health and well-being. 3 specific air pollutants were identified as being highly linked to kidney damage and chronic kidney disease. These are sulfur dioxide, carbon monoxide, and PM2.5, which are any particulate matter that are 2.5 microns in diameter or smaller. Like the analysis performed for water quality, to study levels of sulfur dioxide, carbon monoxide, and PM2.5 in the air across the U.S. and how they may be linked to CKD prevalence in the U.S., 2 different data sets were used. The first data set was air quality data gathered from the U.S. EPA Air Quality Monitoring Program. The data contains test results for the 3 pollutants of interest from air monitors located throughout the U.S. Test results are from the year 2022, and the data used for the analysis were sample longitude and latitude, pollutant name, test result, and unit of measure of the test result. The second data set was the CKD prevalence by U.S. county, gathered from the U.S. CDC under the Kidney Disease Surveillance System for the year 2019, which was also used in the water quality analysis. Each of the three pollutants has a safety limit set by the EPA for allowable concentration in ambient air. These are for sulfur dioxide, 75 parts per billion, for carbon monoxide, 9 parts per billion, and for PM 2.5, 12 micrograms per cubic meter. Box plots were created for each contaminant to display the spread of data. The dotted red line in each plot shows the EPA safety limit. Based on the box plot visualizations, for sulfur dioxide, a very small percentage of test results are outliers above the EPA safety limit. For carbon monoxide, no test results exceeded the EPA safety limit. All results were well below the limit. For PM 2.5, most results exceeded the EPA safety limit. The stacked bar chart at the bottom of the slide shows the proportion of test results that were at or below the EPA limit and above the EPA limit for each air pollutant. From these results, sulfur dioxide and carbon monoxide in ambient air are at safe levels and do not pose a risk for CKD prevalence in the US. For the next analysis, PM 2.5 was studied more closely. All test results at or below the EPA limit were removed from the data in order to study locations with PM 2.5 exceeding the safety limit for air quality. The two sets of data were combined to create a map to display CKD prevalence in U.S. counties, shown in blue, as well as locations of unsafe levels of PM 2.5, shown in red. Revisiting the prevalence of diagnosed CKD first, the counties with the highest prevalence of CKD are located in Hawaii, Southern California, Southern Nevada, Florida, Appalachia, and the Midwest. Based on the PM 2.5 concentration data, many of the counties that have higher prevalence of CKD are also areas where air with PM 2.5 above the safe limit has been detected. In the Rocky Mountain region of the US and some clusters in the Midwest and South, where there is lowest prevalence of CKD, there are also fewer occurrences of PM 2.5 measured above the EPA safety limit. Based on these clusters of PM 2.5, it is likely that PM 2.5 in the air is a contributing factor to nationwide prevalence of chronic kidney disease.
The final factor TechStat looked at in terms of relations to chronic kidney disease is food access. Food access in this instance means accessible food from a supermarket or from a fast food establishment. The main reason we wanted to explore this is because there is research showing that diet can have an influence on chronic kidney disease. The thought process behind this analysis was that populations that have less access to supermarkets carrying healthier food options may have more access to unhealthy foods and fast food, which may have an impact on chronic kidney disease rates. So for this analysis, we took a three-pronged approach. We looked at populations living in food deserts and chronic kidney disease rates by state, the number of fast food establishments and chronic kidney disease rates by state, and income level and chronic kidney disease rates by state. 3 separate data sets were used for this analysis. The CDC provided a data set showing chronic kidney disease rates by state. The food access data set was provided to us from the U.S. Department of Agriculture. And lastly, the data set containing the locations of each fast food establishment in the U.S. came from Datafinity. To begin this analysis, we looked at the rate of chronic kidney disease per 100K people by state. States like Louisiana and other southern states appear to have higher rates. Next, we wanted to determine how food deserts impact chronic kidney disease rates. In this instance, a food desert is means anyone living more than 1 mile away in an urban area or more than 20 miles away in rural areas from a supermarket or a grocery store. Many states have more than 20% of their population living in food deserts. Next, we wanted to look at the correlation between the percentage of population living in a food desert and chronic kidney disease rates. We were able to see a positive correlation of 0.2. Next, we wanted to look at fast food establishments and how they correlate with both chronic kidney disease rates and food deserts. The thought process here was that areas considered food deserts would have larger amounts of fast food establishments, but that was not the case. There was a correlation of negative 0.43. We also looked at how the number of fast food establishments per 100K people impacted chronic kidney disease rates. Surprisingly, there was little correlation with a coefficient of negative 0.18. Next, we wanted to investigate how income levels affect chronic kidney disease rates. We started off by looking at populations that are in the low income category and also live in food deserts. The thought behind this was low income families may not have the resources to travel or pay to get healthier groceries. There was no correlation between the two. Continuing with investigating income levels, we looked at how living at or below the poverty line affects chronic kidney disease. Again, the thought was that poverty makes it more difficult to eat healthy or have access to healthier foods. There was a small positive correlation of 0.12. Now we will talk about what we were able to conclude from this analysis. From the models, we were able to conclude a few things. The model that worked best in this instance was a decision tree using the 5 features selected using a PCA. The model itself was effective at predicting chronic kidney disease, and we believe this model could be expanded to look at kidney damage as well. Lastly, this model could become even more effective with a larger data set. So now the conclusions that while looking at the environmental factors are as follows. We saw that PM 2.5 is highly linked and can have a high contribution to chronic kidney disease rates in the U.S., but in terms of water contaminants, no link was found. The conclusions made from the food access analysis are as follows. There is a large percentage of population living in food deserts, meaning they have low access to fresher, healthier food. The amount of fast food establishments are significantly higher in California, Texas, New York, and Florida. And most importantly, populations living in food deserts have a slightly higher risk of chronic kidney disease. And then finally, income levels have very little impact on chronic kidney disease rates in the U.S.
Now that we have discussed the data sets and the various analytical and model development activities that were undertaken as part of this project, it's important to look at how the project team enabled users to interact with the data and glean important insights. To that end, we have developed prototypes for both a web application and a mobile application that feature dashboarding capabilities and a predictive endpoint. We'll give a high-level overview of both applications and then proceed to a live demonstration that will detail the functionality contained within the prototypes. The web application features 3 different views. First, there is a predictive component that allows users to input health-related values and receive output related to their individual risk of developing chronic kidney disease. Second, there is a dashboard view that is geared towards providers and allows them to interact with their patient data, as well as do some more detailed analysis based on their needs. Finally, there is an information page that aims to provide content that allows users to educate themselves about chronic kidney disease and potential risk factors that can contribute towards its development. The design of the web application is highly modular, meaning that making changes to the application can be accomplished quickly and with relative ease. Content can be added or removed with minimal effort, enabling an agile development and feature delivery pipeline as new requirements come to light. The Dash package from the Python programming language was chosen as the primary development tool, as it is extremely flexible and has innate support for all the functionality necessary to produce a valuable, user-friendly tool, including custom visualizations and web pages. The project team also developed an Android mobile application that provides users with a very similar experience to that of the web-based application. Android Studio, a freely available software developed by Google, was leveraged to create the application, with custom Java code serving as the basis for all the functionality you will see in the demonstration. The mobile app was developed in such a way that it will be able to run on over 95% of the Android devices that are in use today, which includes both cellular phones and tablets. Next, we'll move on to a live demonstration of both the web and mobile applications. As you can see on the screen, we have included a link to the web-based application with this presentation. The application has been deployed to Google Cloud Platform, not only to enable this presentation, but also to demonstrate one of the deployment options for this application when the time comes to roll this out to the public. So we'll click on this link, and as you can see, in my browser, the web-based application has opened. It has opened on the predictions page, which serves as the home page for the web-based application. Now, there are 5 values that we ask users to input: specific gravity, hemoglobin, packed cell volume, whether or not they have hypertension, and whether or not they have diabetes. These values are all fed into the decision tree classifier behind the scenes that was developed as part of our model development process. The model includes both the principal component analysis and the feature reduction steps that were done and resulted in a very, very high training and testing accuracy. So now we can put in some values. So we will enter values for a theoretical patient. We've also included some common functionality that you'll see in many web-based applications: the ability to easily change values, a drop-down list for categorical input, as well as the ability to search or type, and a submit button that is very clear and easy to see. Now, once we hit this button, we will receive some output that will relay the relative risk that this patient has with regard to developing chronic kidney disease. After hitting submit, you can see that this patient apparently has a higher risk level for developing chronic kidney disease. We've also included some text that encourages the people that use this site to consult with their primary care physician if they feel that they are at high risk or they have questions about chronic kidney disease, as well as a disclaimer that the output from this is not a substitute and in no way constitute a diagnosis by a licensed medical doctor. Moving on to the provider overview, which is the dashboard component of this application. As you can see, before we are allowed to access this page, we are requiring that users authenticate with a username and a password. So they must have valid login credentials in order to log into this page. That's due to the sensitive nature of the information that will be seen on here. This is HIPAA data, and we want to make sure that our providers that use this can interact with it in a secure manner so that no data leaks occur. So we'll go ahead and log in here. As you can see, I've successfully logged in. Now, this dashboard page geared towards providers has common functionality that you'll see in many vendor-specific dashboarding software. We've included filters. We only have 2 at the moment. These serve as examples of what can be done, and more can be added or taken away as necessary depending on what the client requires. We've also included an overall patient summary that shows the total patients and the number of patients with CKD and the number without CKD. We've also included a detailed view, or the patient list, that allows the providers to look and see all of the healthcare-related information that we have access to within this data set. In addition, we've included several visualizations that are commonly used to give a high-level, at-a-glance view of some very specific things related to how the patient data is distributed. Now, these can be added to, subtracted from, however the users require. Things can be customized to their specific needs. Now, just a little bit of a demonstration on the particulars. So the filters are designed so that they will cascade, so meaning that you select a value, all of the components in this page will reflect the subset of data that applies from those filters. So if we wanted to look at all patients that have chronic kidney disease, you can see patient summary has updated. There are 250 total patients in this data subset. All of them have CKD. You can also see that where there was once 40 pages worth of data, there is now 25 pages of data. We have limited the patient list to only show 10 rows of patient information per page for ease of viewing. We've also included some more functionality on the patient list. So you can easily page through the entire patient list one at a time, or you can go to the very end very quickly. We've also included functionality to be able to edit this patient list as patient data is constantly changing. So for example, this patient here is missing a value in the specific gravity column. So we have the ability to edit this with a new value. We also have the ability to undo that should the value have been entered erroneously. Additionally, we can add rows of data as needed. So now we will add a row with patient identifier 501, and this patient is 65 years of age and has a specific gravity of 1.01. We've also, in addition to being able to add rows, given the ability to remove rows. So, for example, perhaps I added this row in error. I hit this button here, and it has been removed from the data set. We also wanted to ensure that providers could export this data if necessary in order to use it as input to some other analytical pursuit that is not afforded by this. So if they wanted to do something in Excel or Python, they can click this export button. As you can see, it downloaded very quickly, and now we can see that the entire patient data set filtered to only patients that have CKD was exported. We can also undo the filters, and that will take us back to the original state of the data. And one final item, we have also included the ability to log out. That way, if a provider leaves their station, then somebody will not be able to come in and get to that information without re-entering a valid user and password combination. Finally, we have the information page, which is an educational resources that will allow users to gain some knowledge around chronic kidney disease, as well as the financial impact that this disease has on the U.S. healthcare system. We've included a number of helpful links that can be accessed in this section here very quickly and easily. We've also included some information about the environmental factors, so air contaminants, water contaminants, things of that nature, that users can take a look at it and see in their geographic area if there are potential impacts to them developing chronic kidney disease. So that is the web-based application. Next, let's take a look at the mobile application. So, as we said before, Android Studio was leveraged to develop this. So what I have done is I am running an emulated Pixel 6 cell phone on my computer, on which I've installed the application, the mobile version of the application. So we can go ahead and click on this icon on the home screen, which is the TechStat mobile application. And as you can see, it opens up right to the predictive component. We wanted to keep the functionality as similar as possible between the web-based and mobile application so that users can have a good experience regardless of how they interact with it. The major difference between the applications, between the mobile application and the web-based application, is simply going to be the view and how the user navigates. Instead of links at the top like you would see in the web-based application, we leveraged native mobile navigation. So users can simply go to the menu and navigate to the page that they want. This is also highly modular, and as updates are necessary, they can be accomplished quickly and easily. The content and functionality of all the pages is essentially the same. It is just optimized for a mobile experience. So for the predictive endpoint, we can also still input values very easily, and then receive output. And the values that I just put in indicate that this patient has a normal risk level for developing chronic kidney disease, but should still talk to their doctor if they feel the need. Now, looking at the providers page, we have the same basic functionality, filters, everything of that nature. And the same with the information page. These links are also still accessible right within the application. And we have also included a help icon in case anybody wants to reach out to us with any questions that they might have. So that is the end of the live demonstration. So we will continue on our presentation. The next thing we want to talk about are our recommendations and areas for future work. So our first recommendation is to expand the collection of patient information in order to improve the predictive model. The data set that we had at the beginning was relatively small, and as we get more information, we can make improvements and get even more accurate and representative results. At this time, we are also recommending that the decision tree classifier with principal component analysis and feature reduction be used for the predictive component of this application. As we get more data, we will constantly reevaluate that to see if there is a better performing model, and if there is, we'll work to implement that at that time. We also recommend partnering with hospital systems and integrating the predictive model and application with electronic health records. This way, we can interact with providers and give them more insights and faster insights into their patients and their risk of developing chronic kidney disease, enabling earlier intervention. The team also recommends leveraging a cloud provider to deploy and scale the dashboard application. At this time, the application is deployed on Google Cloud Platform, but Azure and AWS are also viable options. Cloud providers will allow you to minimize your cost, investment in infrastructure, maximize your scalability, and minimize your downtime when you are making updates to the application. In order to increase our potential user base, we also recommend developing an iOS version of the mobile application in addition to the Android version. This will significantly increase the potential user base and allow us to permeate the marketplace with our application. Finally, we feel that educating the public about the environmental factors related to the risk of developing CKD is extremely important, as well as the general knowledge about CKD and its potential health impacts. Specifically, citizens in areas where PM 2.5 is at high levels should be made aware of this and know that wearing a mask when outdoors or investing in an air purifier when they are indoors will greatly help reduce the levels of PM 2.5 and potentially minimize their risk of developing chronic kidney disease. If there are any questions or any clarifications that you might need, please let us know, and we will respond with an answer as quickly as possible. In closing, the project team would very much like to thank the CEO for his guidance and support over the duration of this project. We made a significant amount of progress in a very short amount of time and are quite pleased with what we have accomplished. Thank you for listening and for the opportunity, and we look forward to speaking with you again soon.